Arthritis, ladies and gentlemen. So, it's actually called osteoarthritis, but most people refer to it as arthritis. There are in fact many forms of arthritis. So the most common is osteoarthritis. Second most common, rheumatoid arthritis. But then you've got the less common forms, psoriatic arthritis for example, juvenile arthritis, reactive arthritis, and the list goes on. There are lots and lots of different forms. I'm going to focus this little video on osteoarthritis. So what exactly is it? Osteo refers to bone, arth refers to the concept of joint, so arthrology for example is a study of joints, and then itis refers to inflammation. So in essence what we're saying is there's inflammation in the joint and it's bone associated. Okay, so osteoarthritis usually affects one-sided, so it's unilateral. It affects either one hip, one knee, one shoulder, as opposed to bilateral. And while I'm here, I'm going to just go off on a tangent with rheumatoid arthritis because that's the second most common cause. As much as it's referred to as an arthritis in the name, it's also got extra articular manifestations because it's actually an autoimmune disorder of the connective tissue. And what I mean when I say extra articular, in that it has got symptoms associated with it. It exhibits clinical signs and symptoms that are not associated with the musculoskeletal system. So as much as it's called rheumatoid arthritis, kind of categorizing it with the musculoskeletal side of things, is actually more a rheumatological condition, and orthopedics and rheumatology of course work quite close together for obvious reasons. So that's rheumatoid. Back to osteoarthritis, and I'll do a separate video on that if you so wish. So osteoarthritis, like I say, it affects one side of the body, it's unilateral. The joints that are usually affected are what we refer to as weight-bearing joints. So those joints that undergo a lot of physical exertion. Here I'm referring to the hip, the knee, the lower back, and the small joints of the hands. While we're on the hand, the most common joint affected is the metacarpal joint, and then the first metacarpal phalangeal joint. In the context of the hip and knee, usually I find it is those patients who are either carrying a little bit of excessive weight, or otherwise those patients who have a long-standing history of lots of impact. So for example, runners, jumpers, and the likes of. Then you've got the patients who have got issues at the lumbar spine, the lower back, and then also those with issues in the neck. Again, the head is quite a weighty area, and inevitably that causes degenerative changes in the neck, what we refer to, so and of course in the back also, sorry, and the back, the lower back is more affected than the neck because again the torso is being carried on the lumbar vertebrae, and so again very, very weight bearing structure. Degeneration in the spine we refer to as spondylosis. Okay, spondyl referring to vertebral body and or the disc depending what reference you go for, osis meaning condition. The area most affected in the neck, the vertebral level, is the C5-6, after which it becomes a C7 and then a C3-4. So what can be done, and what exactly happens rather first in osteoarthritis? So essentially what we've got is we've got two articulating surfaces, two bones. They come together like so and articulate. Now on each of these bones there's a covering. That covering, cartilaginous covering, so it's cartilage, and it's a specific type of cartilage known as hyaline cartilage. And what happens over time is you get degeneration of this hyaline cartilage, and in doing so, as that wears away, what happens, the bone underneath it, that becomes exposed. Now bone, the periosteal layer, what we refer to here, the subchondral periosteum, and that periosteal layer is very, very, very highly innervated, which means there are lots and lots and lots of nerve endings in there. As a result, it's very, very sensitive to anything and everything, particularly nociception, pain perception. This is analogous to our tooth. You lose a crown, and all of a sudden you get massive sensitivity. You can be drinking a glass of water, for example, and it will be very, very sensitive. And it's the same reason. So that crown is equivalent, or the enamel is equivalent of the actual hyaline cartilage on an articulating surface. Now, in degenerative changes, in osteoarthritic change, in OA of a joint, we don't just get wear and tear of the actual cartilage. There are changes to the actual synovial fluid, as well as degeneration of any associated structures in the area. For example, in the knee, we have menisci, and they also will inevitably start to undergo degenerative change. Okay, so as a result of those situations, the knee, what we also then get is we get debris in the knee, and that's part of the reason we have this sensation when we move a joint. You get this kind of grindy sensation. It's what we refer to as crepitus. Now, please don't let me mislead you and suggest that crepitus is indicative of debris in a joint. No, it is not. In fact, there have been studies carried out to get a better understanding of practitioners' understanding of crepitus, and it is not at all associated with that. Okay, crepitus is another kettle of fish, so I'm not even going to go there. But if there is crepitus in excess of what one would expect, or if there are other clinical signs of debris in a joint, then yes, that there is consideration that we ought to the joint we ought to promote or otherwise refer for a debridement. Okay. In terms of the pain itself, why do we get pain then? So like I said, the wear and tear of the cartilage. What I also find is in practice, aside from the etiological factors that I mentioned, cold weather always makes osteoarthritis change worse, with the exception of a few patients that I've had. Okay, with the exception of very few, cold weather makes it worse. Why? Because again, if you consider the two joints, they are so far apart normally. Now, in the context of arthritic change, they come closer together. The joint that was nice and smooth is no longer so because of the wear and tear. It is now non-congruent, and there are muscles that cross the joint. Those muscles, they tighten. They tighten. What I mean by that is they contract in the cold weather. Muscle, when we go out, we shiver. Shivering is muscle contracting. A, because it's increasing the rate of respiration, which is an exothermic process to increase the core metabolic temperature, and secondly, it's converting kinetic energy to thermal energy, and therefore keeping us warm. So, or trying to at least. And so that's the concept there. So now muscle contracts. Now in contracting, if I've got muscles crossing this joint, what's going to happen? Well, inevitably it's going to go closer together and again cause physical contact, and that's why in the cold weather arthritis is usually made worse. I usually recommend heat. There are practitioners who are totally against that concept. I'm sorry, if the patient says it works, it works. I believe, and my understanding of heat is that it's a muscle relaxant, and so therefore again it allows the muscle to relax, thus allowing the joint to part a little. So there's heat. Massage, self-manipulate very gently, release the soft tissue tensions, articulate the joint, keep it mobile so as not to allow things to stiffen. And rehabilitation, so exercise is imperative. In degenerative change, tendons weaken once they undergo atrophy. Tendons start to lay down type 3 collagen, and what we actually want is type 1 collagen, because type 3 is nowhere near as structurally sound as is type 1. And then finally, we've got the pharmacological interventions. And unfortunately, this is, I'm going to call it a downward spiral because it actually is. And it's a matter of trying to really either, if you've got risk factors that are causing you, predisposing you to arthritic change, such as excessive weight, then address the root cause. If, however, and this is a very important final point I'm going to make, not all osteoarthritic change is associated with physical exertion. There is an underlying genetic predisposition, as literature is increasingly suggesting. And there is increasing acceptance of that in light of the fact that the likes of the GH joint, which is a non-weight bearing structure, is also undergoing degenerative change. A pharmacological intervention, standard analgesia, paracetamol, NSAIDs, cocodamol, codadromol, tramadol, morphine, and so on and so forth. Thank you very much for listening.